Good morning. My name is Jessica Kumar. My presentation is dedicated to public health care burden that affects 56,000 Australians this year alone. According to the Australian Stroke Foundation, that's one stroke every 9 minutes. But here's the fact that I'd like you to focus on, which is more than 80% of stroke can be prevented. My presentation will cover the clinical manifestations of stroke, whilst highlighting the pathogenesis causing the clinical manifestations by drawing on the case study of Mr. Marks. Mr. Marks is a 68-year-old gentleman who was admitted to emergency department at 6 a.m. Since admission, he has been diagnosed with left middle cerebral artery stroke. It is important to note that the patient has a history of hypertension, which was diagnosed 2 years ago. Arden Johnson, 2019, state that it is essential to use the FAST acronym to identify the signs of stroke. I'd like to point out the clinical manifestations that are present in Mr. Marks' case study on admission at the emergency department using the FAST test. Mr. Marks presented with right-sided facial droop, arms, severe right-sided weakness, speech, incomprehensible words or slurred speech. Time is crucial. Mr. Marks was admitted to the emergency department at 6 a.m. Other signs and symptoms may include, or a combination of, for Mr. Marks, decreased level of consciousness, GCS of 11 out of 15, eyes 3 out of 4, voice 2 out of 5, and motor 6 out of 6. Right hemaniopia as well. Klaus et al. States that another critical factor is that clinical manifestations of ischemic stroke differ depending on the artery obstructed. Different sites of obstruction contribute to different occlusion syndromes. Therefore, if the area of damage is unilateral, it will entail that the damage is restricted to one side of the brain. The symptoms will appear on the opposite side of the brain, meaning contralateral. Now I'd like to draw your attention to the pathogenesis of stroke. Broadly speaking, a stroke occurs when a blood vessel delivering the brain with oxygen and nutrients is altered. According to Barton and Johnston 2019, strokes are classified by their pathophysiology. Ischemic strokes cause the blockage of cerebral vessels supplying brain tissue with blood rich in oxygen and nutrients, whereas a hemorrhagic stroke involves bleeding from the cerebral vessels into the brain tissue. Hemorrhagic strokes can be categorized into two types: intracerebral, caused by hypertension or a ruptured aneurysm. Subarachnoid is due to bleeding into the subarachnoid space that contains cerebrospinal fluid. Ischemic strokes are categorized into thrombotic or embolic strokes. A thrombotic stroke can further be broken into subcategories. Firstly, with cerebral thrombosis commonly caused by a blockage in the carotid artery or smaller vessels within the intracranial vessels, atherosclerosis is typically the process responsible for the blockage formed by fatty plaques. Secondly, a transient ischemic stroke or mini-stroke that initiates when the blood flow to the brain is temporarily interrupted, then restored. Thirdly, a lacunar infarct happens because of an occlusion of a single penetrating branch of the small cerebral arteries. An ischemic stroke gives rise to an embolic stroke. Due to the effect of atrial fibrillation, embolic fragments break away and travel to the brain. Once the emboli are lodged into the small vessels, causing occlusion, ischemia may result in brain tissue distal to the occlusion. So to recap on a point made earlier, the symptoms will appear opposite to the side of the occlusion. Mr. Mark has a left middle cerebral artery stroke. The middle cerebral artery supplies the frontal, temporal, and parietal lobes with oxygenated blood, hence the right-sided facial droop. Severe right-sided weakness, aphasia, altered consciousness, and right hemaniopia. Speech production is coordinated with the Broca's area, which is situated in the left frontal lobe of the brain. Mr. Marks' diagnosis of hypertension is a lifestyle stroke risk factor that links to the underlying pathogenesis of his current exacerbation. Once stroke has occurred, it is important to identify if a hemorrhagic or ischemic stroke so that the correct treatment can be commenced. The initial management of ischemic stroke is through perfusion of the still viable brain tissue. MIMS Australia 2019 states that once hemorrhagic stroke has been excluded, alteplase should be administered as early as possible intravenously to suitable patients. The nursing considerations that should be followed after administration of thrombolytic drugs are to watch for bleeding. Bleeding whilst on such drugs are fatal. Therefore, keeping an eye on cannula sites, avoiding injections, and avoiding invasive procedures is imperative. Reperfusion can be achieved by thrombolytic drug therapy or by mechanical thrombosis. Vindically et al. Showed that an endovascular clot retrieval procedure conducted in interventional radiology is used to remove blood clots, occluding a brain vessel through an intra-arterial approach. Close observations are required prior to, during, and after these reperfusion procedures to detect early neurological deterioration that may signify complications from treatment. As a nurse, my priorities during the exacerbation of Mr. Mark's condition at the bedside would be to monitor the patient's airway, do the A2G assessment so that I can assess breathing and see the patient is at 95% of oxygen. I'd monitor the heart rate, blood pressure, GCS, temperature, fluids, blood sugar level. If I notice the patient deteriorating, I would call a clinical review of a MET call. Depending on the severity of her assessment, I'd notify the stroke team. Studies such as Banke 2019 emphasized the phrase time is brain. The optimization of time management during the complete acute diagnosis and treatment procedure is of utmost importance regarding the efficiency of the treatment. The severity and irreversibility of brain injury increases as time passes. The primary goal of acute ischemic stroke is the stabilization and reperfusion of the ischemic penumbra. According to Bard and Johnston 2019, the ischemic penumbra is the tissue lying between tissue that is normally perfused and the area in which infarction is developing. Though the area within the penumbra may remain viable several hours because the penumbra zone is supplied with collateral circulation. In summary, it is vital for nurses to prioritize the care for Mr. Marks by providing him with early interventions once they have stabilized airway, breathing, and completed the A2G assessment. It is crucial to establish reperfusion because time is brain. Thank you very much for listening.